I'm George Monks. I'm president of the Oklahoma State Medical Association, and I wanted to welcome all of you to today's discussion, which is very important and very timely. It's about maintaining mental wellness during the COVID-19 crisis. And so I'm really excited about this program today. Just a couple of housekeeping notes before we get started. First and foremost, I want to thank you, and I want to thank our presenting sponsors who have made this CME possible. And we want to thank PLICO, the Oklahoma State Medical Board of Licensure and Supervision, and the Telegen Community Initiative. I'd also like to thank OSMA's CME manager, Sandy Deba, Sharon Westmoreland, who's our IT manager, and Jennifer Dennis Smith, who's our communications manager. And with that, I also wanted to add that information about how to receive your CME credit can be found on our website at okmed.org. That's okmed.org. You can also find copies of today's presentation as well as some other information about the speakers at that website as well. Without further ado, it's my honor to introduce our presenters today. And we have two great ones. We have Dr. Gerard Clancy, who's the immediate past president of the University of Tulsa. He is the graduate of the University of Iowa with degrees in biochemistry and medicine. He served as a flight surgeon in the United States Air Force with specialty training in aerospace medicine, survival medicine, and hostage negotiations. He's also a graduate of Harvard University programs in health policy and management and nonprofit financial stewardship. In 2008, he led the establishment of the University of Oklahoma, University of Tulsa School of Community Medicine. In 2015, he led the establishment of the University of Tulsa's Oxley College of Health Sciences. He has led the creation of numerous clinical and educational programs, including outreach mental health services for the homeless, school-based clinics, the Bedlam Evening Clinics for the uninsured, the Wayman Tisdale Clinic in North Tulsa, and Tulsa's Albert Schweitzer Fellowship. Our second presenter today is Dr. Phebe Tucker, and Dr. Tucker serves as the editor-in-chief of the Journal of the Oklahoma State Medical Association. We're happy to have her there. She's also the medical director of the Oklahoma Medical Society's Physician Wellness Program, which is such a very important program here in our state. That's specifically designed to help physicians fight burnout and stress. Dr. Tucker is Vice Chair of Education and the Ungerman Endowed Chair in Psychiatry at the OU Health Sciences Center. She has conducted published research on PTSD, trauma, anxiety disorders, and education, and has an active clinical practice. So prior to medical school, she received a BA in English literature at the UC Berkeley and served in the Peace Corps in the Ivory Coast. She also taught in California and Australia. And with that, I wanted to begin today's formal presentation. What we plan to do is we'll have both of them present their subjects. And hopefully at the end of this, we'll have some time for questions. And to do that, just to let you know, we want you to please type those comments into the comments section of the YouTube page. And time permitting, we'll try to get to those questions if possible. On a last note, the faculty, OSMA CME Planning Committee, reviewer and moderator have no relevant financial relationships to disclose, and the OSMA CME manager has reviewed all information and has resolved all conflicts of interest if applicable. Dr. Clancy, the virtual floor is yours.
Thank you, George. Thank you. Well, I think we as physicians, we read a lot and we observe a lot, and we're seeing quarantine fatigue in our communities. Here in Oklahoma, we've seen record sales of alcohol. We've seen breaking record sales of marijuana purchases. Our restaurants are open, and I was coming down Cherry Street in Tulsa a few nights ago, and I saw the outdoor patio areas of several restaurants absolutely packed. And that caused me concern, because I think we all know that we'll probably have a return of the virus in the fall, coinciding with winter weather and with the flu. But I'm also worried about what happens as we ease some of these restrictions that we've had before. So this is a good time to be talking about well-being, because I think we all need to be prepared for the long haul on this. And part of the good of this is that the Oklahoma State Medical Association is moving very quickly. I'm amazed how quickly we were able to put together this program. And part of my talk will be talking about the pieces of a well-being program for a pandemic that the State Medical Association is putting together in an incredible way. So let's move on to the next slide. So this is part of a 3-part course that I have put together. This first part is the immediate needs. The second part is looking at long-term systems for clinician well-being. And then part 3 will be on the long-term mental health needs of our communities. I've given part 2 to the State Medical Association last month, not knowing that we would need to put these into different parts, but we'll make those available as well. And I have no disclosures and no conflicts, as George said. Next. So let's begin with really the immediate needs, and let's go to the next slide. What I want people to come away with is really what we've learned from past disasters. And then what I want to talk about is the unique aspects of this pandemic on our frontline healthcare workers. Introductory frontline healthcare worker well-being strategies, and some of them are relatively simple and effective at the same time. And then finish up with what we should be building for the long haul as far as a comprehensive system for our frontline workers and the rest of our clinicians as we work through this really over the next possibly 18 to 24 months. Next slide. Knowledge is power, and we've learned a great deal from past disasters. We've seen pandemics and epidemics in the past. In 1918, we learned a lot from the Spanish flu and what social distancing could and could not do. I was a fourth-year medical student and then an intern when AIDS really began rolling in Iowa. And it was a very concerning time because we didn't know, just like now, we don't know what it's going to look like in the future. We've learned from SARS and MERS and Ebola. I did my residency at the University of Iowa, and we had a terrible farm crisis and economic depression in the late 80s and early 90s, and we had a huge increase in farmer suicide. So mental illness and economic declines are inextricably linked often. Saw the same thing with disasters with 9/11 and with Hurricane Katrina. The closer you lived to ground zero, the more likely you were to have post-traumatic stress. As much as 20% of people that lived in lower Manhattan had post-traumatic stress after 9/11, whereas those up in the northern parts of Manhattan Island, not near as much. We know that healthcare workers are resilient people. They're a group that really is, they know what they're getting into. We know what we're getting into, and you hear it over and over again on the stories of, this is my job and I knew what I was called to do. But interventions can help. And that's what we're here today, is that it can release stress and it can relieve recovery if things do head in the wrong direction for a particular individual. Next slide. We also know that COVID-19 is unique. It's occurring over months and maybe even over years compared to a one-time event. It has high rates of transmission, and we're continuing to learn about how high and how quickly it can transmit. It does last on surfaces. It has a long incubation period, and so you can be asymptomatic for quite a while. Many individuals are asymptomatic or have minimal symptoms. And what we're hearing from the frontline workers is that it can go bad very quickly. Someone can present that doesn't look that bad, but then when you look at their vital signs, they're in not good condition at all. They're really, really struggling, and it can go very bad very quickly. Here in Oklahoma, we're one of the leading states in young people having COVID-19 related strokes as well. And so here's a young person presenting with a stroke, and that needs to be considered every time we see a stroke now. Is this a COVID related stroke as well? Next slide. We also know that there is an impact on these social restrictions on our own personal support, our family support, our coworker support, jobs, income, and the economy. A whole part of the healthcare system is very much stressed because the usual flow of patients and procedures and visits is not happening near to the extent that it had in the past. That's very stressful on the system. How are we educating our children? And then we have the opportunities for frontline workers, but with the social isolation that comes with it of non-congregate sheltering of frontline health workers. We have hotels that are offering places for those workers to be safe away from their families, but that comes with a consequence as well. Next slide. It's important for us to acknowledge what is happening and to talk about it and then plan for it. And that's what the rest of this talk is about. Let's go to the next slide. Some of the clinical pressures include that we're worried about infecting others. We're worrying about being infected, stamina, long hours in difficult gowned conditions, difficult decisions minute by minute on use of resources, struggling with enough personal protective equipment. Enough ventilators so far seems to be adequate in Oklahoma, but we do need to be prepared for what comes in the future. And we know that elective surgeries and procedures for the most part are now just opening up, but there's a lot of patients that have waited a long time to get what were quote elective, but were very important procedures to have. And then we know our critical access in rural hospitals are struggling with that decrease in flow of patients as well. Next slide. One of the things that's happening is from back in our educational experiences related to Abraham Maslow, when he put together his hierarchy of human needs. And we as clinicians are used to working at the upper levels of Maslow's pyramid, where we're working on the behalf of others. And it's rewarding work, it's fulfilling work. But at the same time now, we're looking at downward pressure on ourselves and on our families of just taking care of the very basic things of food and of safety. And so we're very torn right now. I remember seeing this when we had the great ice storm in 2007, that our healthcare workers were worried about family at home with no power. At the same time, we're needing to come to work as well. And we're seeing this again. All right, next slide. And there are some initial research is now coming out on the impact of the COVID-19 pandemic on those frontline healthcare workers and their well-being. And we're seeing that 75% of them are exhausted and noting mental distress, 50% of them noting depressive symptoms, 50% noting anxiety symptoms, and another third with insomnia. So it is having an impact on them. And it's important to intervene. And what I'm proud about with the State Medical Association is they are intervening and they are making services available in an easy way. Next. It's good to think about this in phases. And we're pretty much past this pre-surge phase where it's dominated by anticipatory anxiety. For me, that was watching what was happening in Italy and then what was happening in New York City and just what was going to come to Oklahoma, what was going to happen to us. We're kind of in a surge right now, and for our workers, dominated by fatigue and worry of mistakes and guilt of not doing enough and guilt about being away from home during a tough time. And then there will be a post-surge time, and healthcare workers are resilient people. But a vast majority will make it through just fine, but interventions can help for those that are struggling, and that's one of the things we're here for today. Okay. There is a range of normal emotions and reactions during a pandemic, and I've had some interviews with the Tulsa World, and one of the things I've tried to push is that it's okay to not feel okay right now, and that people are having a normal reaction to a very abnormal situation, and it's normal to experience fear. These are known threats. And it's normal to have a fight or flight syndrome that comes with it. And it may go up and down from day to day. It's normal to be anxious as well, which is that unknown, more diffuse apprehension feeling that we feel as well. It's more looking into the longer future, and that's where that anxiety comes from. And it's normal to be sad. It's normal to be sad. This is a tough time. There's lots of suffering out there as far as human loss and lots of suffering as far as economics. And it's okay to feel upset about making mistakes as well. My wife and I were picking up some food one night, and she didn't have her mask on and she didn't have her gloves, but she had her window down, and she was surprised by one of the workers delivering food to her who did not have gloves or masks on. And suddenly my wife felt like she had made a terrible mistake that had put our family at risk. And I had to say, it's okay. You don't have to be perfect through this. It's okay. It's okay. But in more intense situations, we are seeing healthcare workers worried about making mistakes. And we'll get back to reframing on that to try to make some of those emotions better on that. Next slide. And it's okay to feel guilt that you're not doing enough. Many of us were trained to help, and we're being asked to stay back. and let the frontline healthcare workers do their duties. Others, we're apart from our families. And then it's okay to feel frustration and angry as well. And I think it's important for we as clinicians to continue to push those that have control over the resources to push and push and push as far as testing capacity, personal protective equipment, and ventilators, and what else is needed. I think soon we're going to have a shortage of remdesivir, and we need to push so that everything can be available to us when needed. Next. So let's move on now to some of the immediate well-being strategies, and then we'll finish up with some of the things that relate to how to build a better system, kind of the best of the best all put together. So let's go on to next slide. Then the first relates to just better preparation for additional global diseases. And that comes back to us as organized medicine pushing for a better system at that national level as far as prevention, monitoring, and planning, widely available protective equipment and testing, ventilators, and helping the doctors and hospitals build surge capacity for if we do have something significant in the fall again. Just so that for me, that's number one. Let's just make sure we don't take our eye off the ball, that we need to push for better preparedness. All right, next. Second is thinking about prevention and early intervention. We know already that physicians have high rates of burnout and clinical depression and suicide. In fact, 40% of physicians before COVID noted burnout, 20 to 25% had clinical depression, and physicians have 2 times the suicide risk of the general population. And we know that disasters increase the risk of clinical depression, clinical anxiety, substance use disorders, and post-traumatic stress. So we know what's coming at us, so it's time to intervene, and we're doing a great job with that. Great. Next slide. I've been to Israel, and Israel has an incredible preventive early intervention system for trauma. They're a country that is under the threat of war and terrorism all the time. And they actually, just as much as they have physical interventions for trauma early on, they also have interventions to prevent post-traumatic stress when a traumatic event happens, and it's very impressive. This is the opposite of what happened for our Vietnam veterans, where we had no system in place. They came back to a country that wasn't accepting of them, and the post-traumatic stress rates just went through the roof. So prevention and early intervention are very important. Next slide. This is from the University of Tulsa, and it just shows that programming works. The yellow line is our prevention and early intervention programming for sexual assaults on our campus. And the blue bars are our retention rates for sexual assault survivors. And you see, as we increased our programming around prevention and early intervention, our survivors were able to come back and be strong and stay in school to a much greater extent. So the point being, programming, intentionality does work. Next slide. And this is some of the programming we've done for our freshmen as far as trying to prevent depression and anxiety, because that's a high-risk time. And the folks at the Laureate Institute of Brain Research put together a program called TU Tough, where it teaches resilience. And the green lines are the intervention group, and you see a huge drop in depression, a big drop in anxiety scores, and a big drop in stress scores for our freshmen after their first semester. Next slide. And the green line again is our intervention group. They noted an increase in cognitive behavioral therapy skills and an increase in mindfulness as well. The point again being, programming works. And what's nice about the Laureate Institute of Brain Research is they're putting together programming for the Oklahoma State Medical Association. We'll have trainings as far as resilience in disaster situations available to our physicians and clinicians across the state as well. Really proud of what they're doing there. Next slide. Some initial interventions. It's important to tailor to what fits you best. And what we hear often is, I just need support. But support is such a big word. And so you need to think to yourself, what is best for me? Is it social? Is it emotional? Is it physical? Is it reassurance? Is it material? Is it feeling needed? I'm one of those persons that wants to jump in, and feeling needed and feeling like I'm contributing is important to me. And it's one of the things that has driven me to help put together some of these talks, in that if I'm asked to stay at home, at least I can intervene with one of my skills, which is being able to educate others. And so you have to do what fits best for you. Next slide. For others, you have to, what's your best coping activities? And you have to seek the best fit for you. And I put a whole list of things here that what might be good for you. One of the ones that's really been helpful for our family is to take a break from the media. We now are down to a half an hour a day of watching the news, so we're up to date, but we're not overly burdened by so much information coming in and worry. For me, I have to run every day. For me, a normal schedule has made a huge difference. And for me, cooking and almost playing master chef or chopped in the kitchen. What's in the pantry today that I can cook? And it's been enjoyable to do that. But what fits best for you as far as those coping activities? Next slide. For others, it might be learning, it might be writing and scholarship, it might be in creating educational materials, such as for me. And sublimation is one of Freud's most healthy defenses. And that's where you take uncomfortable emotions and the energy from that, such as anxiety, and you transfer it to positive actions. And that's a really good thing to be able to do. Great. Next slide. And I think it's important to also, we clinicians are hard on ourselves. We're harder on ourselves than we are on others. And it's not uncommon for us to really beat ourselves up when things don't go well. And so it's important to correct self-talk and negative emotion or negative thoughts and self-talk can really lead to negative emotions. So it's important to reframe and correct those and test the accuracy of those thoughts. And one of the best ways to do that is, what would you tell a friend who was thinking as you were? And how do you walk through that as far as reframing the situation that you did your best, you're working hard, you're putting in the hours, no one's expecting perfection right now. Next slide. And I get asked this a lot. Well, what do I do with sudden panic in a clinical situation? Just suddenly I'm overwhelmed. If you can, take a break, and it actually works really well. Slow down, steady breaths in and out, and it really works for others, sometimes just over about a 30-second time period, and it just resets the brain, it resets the heart, and people feel a lot better just with some slow, steady breathing techniques. It can make a big difference for them. Next slide. And there's helpful phrases to use on yourself as well, as far as trying to show the positive. One of the things that I've noticed among clinicians is they can do 20 things well, and if one thing goes wrong, they will dwell on that one thing. So it's important to come back and say, what did you do today that was helpful? How did you show compassion today? And it's also okay to acknowledge that it's okay not to be okay right now, as we just talked about. There is a lot of suffering out there, and it's important to grieve. Next slide. And then longer term, and this is one of the things that I'm really proud to see the State Medical Association, OSMA, working on, is building a better system for well-being. And this is kind of the greatest hits well-being during a pandemic. And no one has done all of these, but what I'm impressed by with OSMA Intelligent is that they're putting together many of these pieces. So we'll quickly go through these. The first is that it needs to be inclusive. What's happening with frontline workers is very much team-based, and so the entire team needs to be included as well, because there's a lot of different people being involved. So the best of those has been inclusive, and it offers it to a lot of the different frontline workers. Next slide. The second is that there's a lot of intention around normalizing interventions for stress management. My alma mater, the University of Iowa, has regular updates through what they call the loop. And every day there's something in there about stress management and resources available, very much normalizing that you're having a normal reaction to an abnormal situation and you might need help, and that's okay. And that's okay. Next slide. The third is a known array of services. And so whether it's just being able to talk to somebody for a short time versus somebody needs more involved counseling versus someone who might need to see a psychiatrist, but there's a known array of services that are built into the system. And OSMA has done that with Dr. Tobin. It's really great to see. Let's go on. Social media has been really effective in some health systems. The University of West Virginia put together a support group through Facebook, and 6,000 people joined within about 2 weeks. There's rules to this. This cannot be a gripe session. It is very much a support network. And in that framework, it is done really, really well as far as people feeling close to others and being able to work through some of their stresses. Next. The University of Iowa has been able to put together a 1-800 24-hour hotline. It's not that busy, 21 calls in the first 14 days, but those 21 that called very much needed services. It was very urgent calls that was needed. So it worked well that way. Let's go on. And a place to start screening, a place that someone can sit down and say, these are my issues, and a person on the other side that has enough knowledge as far as how serious this is to be able to triage somebody to the right place at the right time. Next slide. And then access to care. And this is one of the areas that the Oklahoma State Medical Association has just done so well of having a bank of clinicians that it's easy for frontline physicians to be able to get help when needed. Michigan has done this as well, and Wayne State has done this as well. And it can be done on virtual sites as well, and through telehealth, and it's done well. Next slide. And then some skills development. And this is one of the things I talked about, that the Laureate Institute of Brain Research psychologists will be developing a resiliency training module that will be offered soon, hopefully through the State Medical Association. And then Stanford has developed a 1-hour CME session, and I put the link there, and I found it very helpful as well. And then attention to family as well. I think it's really important that this doesn't happen just in the hospital and just in the clinics. This is happening in the broader life of our clinicians. And so there's been some real creative ways to do it. University of Iowa had Zoom dance parties for the employees' kids, and it was a big hit. And then one of the other areas that I've noticed is that clinicians are worried about going home. And are they clean enough to go home? And so setting up systems so that they can clean themselves as much as possible before they go home, if they're going home, rather than to a hotel. Great. All right. So I'll quickly move through that, and hopefully just gave you some basics on what we've learned from past disasters, some of the immediate interventions we can do for ourselves, and then lastly, what we need to build a little bit longer term for long-term attention to clinician well-being during a pandemic. Thanks.
All right, well, that was great. And the next, we're going to have Dr. Tucker coming up. And just as a reminder, you can submit those questions to the comments section that you're watching from. And at the end of it, if we have time, we'll look at some of those questions. So Dr. Tucker.
Thank you. First slide, please. So we're looking for the slides.
I'm sorry, I'm transiting at the moment.
Okay. So it is a pleasure to follow up on Dr. Clancy. He did a wonderful presentation on how to help our healthcare providers. And so today I'll be talking to you about how we can help our patients. And many of us notice that our patients are having a whole lot of issues related to COVID-19. Next slide. So we're going to talk about what happens psychologically when people are quarantined, or I think, as I'm reminded, it's not really social distancing, it's physical distancing. And also the effects of the epidemic itself on our patients. And then we'll talk about the emotional needs of individual groups that have extra needs. So that would be homebound children and their parents, isolated individuals, elders, people who are more at risk, and people who may be stigmatized or disadvantaged. And so we'll talk about resources for helping patients, not only patients who are not having a lot of problems, but especially those that are having significant mental health problems. And many of the slides that I'm producing could be used as handouts to either physicians caring for patients or to patients, because they include resources. So next slide, please. So Dr. Clancy talked about common reactions that can happen for any disaster. Actually, and we've passed the 25th anniversary of the bombing, so we're familiar with many of these reactions from then, 25 years ago. So, we have a lot of fear, maybe changes in sleeping and eating patterns, detachments, feeling on edge. But added to those would be financial fears and concerns, real fears, and also concerns about becoming ill, desperately ill. And I hear patients afraid that they're going to die. So next slide. This is from the Department of Mental Health and Substance Abuse Services. And so as we kind of tease out the different stressors that our patients have, one is just fear of the virus itself. And so one of the issues for our patients is they're getting mixed information that constantly changes. And as Dr. Clancy also mentioned, kind of an overload of things through the media. And so the questions that folks often have is, so when is it safe to open up? And then there's also the competing concerns about the economy and people needing to work. And who's in charge of figuring out when we open up? Then a lot of folks are concerned about, is there going to be a second wave of illness or a third wave? Has the virus mutated? And then the unanswered question, if somebody has had corona and survived, are they now immune? Another big fear our patients bring forward is that, well, right now there's no vaccine, although we have hope that there will be one. And there are really few treatment options, and there's been many things talked about that may or may not be helpful. Of course, the severity of the illness and the fact that it's very contagious is also a problem. Many of our patients fear for their elder parents or loved ones or relatives who are at risk. And then testing not being available easily or taking quite a while to get the results back while people are quarantined. And next slide, please. So as we talk about another stressor, social distancing is a big one. And so it's especially a problem for people who are isolated. So elders who are alone, adults who are single, and other segments of the population, undocumented immigrants, homeless people, and those who have mental illnesses. Another problem is relates to supervising your kids at home with their schoolwork or their play while you're working full-time at home. And so I have a lot of patients juggling with that. We rely on the internet so much for patient care, for education, for meetings and interaction, and there's a lot of connection problems. And I know we all, if we're doing telehealth, we get less exercise just getting up and about, but people who are homebound have a lot less exercise unless they make an effort to get out. So when we look at research about the mental health effects of social distancing with COVID-19, it's a bit early to know about that. Most of the research on the mental health effects of epidemics focuses on the effects of the disease itself. But it's predicted with this pandemic, there'll be increased anxiety and depression, addictions problems, and domestic violence. And of course, with schools closed and kids at home getting underfoot, there's concerns about child abuse. And there actually have been some studies on the internet that are looking at, they're unofficial, they're not actually published yet, but they are identifying an increase in depression and anxiety symptoms among adults, especially those who are distanced. Next slide, please. So how do we help people with the social distancing? Kind of obvious thing is to decrease isolation. And so hopefully they have access to the internet, because there are wonderful groups on the internet for yoga, exercise, religious services. And we know more and more people are using video outreach and social media. Savvy workplaces often have virtual workspaces where their coworkers can kind of get together and check up on each other and interact. And then for school children, how do we help them? Well, routines are helpful for kids. And then having internet access, so important for their education these days and for socializing. So for children who have fewer economic resources, very important to help them get that internet access. We need to be able to figure out when child and domestic abuse is happening and how to intervene. And then very, very important, we have to enhance our mental health care system. So fortunately, telemedicine has come to the rescue when it works. And It's able to reach people who are in isolation, and very importantly, reaches our patients in rural areas. And they are often underserved for psychiatric care. So there has been a recent Medicare increase in reimbursement for phone sessions, very important. A lot of times our elders don't have access to internet and they don't like to use their smartphones. And also there's expanding coverage for social workers and psychologists to do counseling online or through the telephone. And also important would be making sure that patients get their medications, especially for mental health issues, but for any medical issues. Next slide, please. So not to be forgotten are the economic hardships that many people are facing now. And so unemployment has been estimated to reach 20%, and that's huge. That's like the Great Depression. So I think 33 million folks have applied for unemployment insurance up to date. Now, the government has come forward with some packages to help. So we've got a stimulus package and increased unemployment benefits. And we really want to help those delays because a lot of people, many people applying, there's a slowdown in some people getting reimbursed. Big issue for us in healthcare, our patients, when they decrease their hours or lose their jobs, may lose their medical insurance. In this state, I think Medicaid expansion is on its way. And shortages. So people go to the store, maybe the supply chain is disrupted, so they may not be able to get certain foods or cleaning supplies. Next slide, please. Now, if we look at mental health needs currently in Oklahoma, there are a few measures of that. Heartline Oklahoma, which is accessed by dialing just 211, is a place for mental health referrals. And the number of mental health related calls, if you can see for 2019 compared to 2020, has gone up fivefold. So lots of people calling in for help. Law enforcement noted that there were spikes in calls for mental health and suicide issues early on. And the visits to emergency rooms and mental health clinics, there have been barriers. Some mental health patients who are having problems may avoid going to the emergency rooms because they're afraid of getting sick or they're concerned that their issues are not important enough. We know that in many times medical clinics have kind of prioritized physical illness in this time, kind of ruling out pandemic problems. Community mental health centers see the lion's share of the chronically mentally ill population. And right now they are scrambling. They're trying to get social distancing on board, really hard in crowded areas. They're trying to protect their staff and patients and also get access to telemental health in any way they can. Next slide. So as we talk about homebound kids, this is from the Center of Study for Traumatic Stress. Supporting the family is extremely important. So we advise the family to schedule activities together, especially physical ones, because kids have so much energy. And then to have chores for the kids, but let them have fun and help them relax as well. So open communication is recommended, and according to the age of the child, you do want to encourage discussion of fears and encourage altruism. Kids do better if they feel like they're helping somebody in some way. We know that children a lot of times are trying to protect their parents, so they may, may need to explore some of their feelings, and they may not want to tell how nervous they are to their parents. So connection is always important. And so for kids, we need to enhance phone and internet connection. Again, they're often homeschooled or doing other types of distance learning. And we want to make sure that if there are problems with aggression, anxiety, or depression, that we get in touch with mental health professionals. So here are some of the resources nationally, and very important, the infectious disease information that the CDC provides there's a section that's appropriate for children. And the Pediatric Association also has information for children. Next slide, please. So this is from the National Child Traumatic Stress Network, and they help children who have experienced trauma, especially from community disasters. But I think this information is extremely useful in this case. So they break down into different age groups because different age groups present their problems in different ways. So for preschool children, they may have issues with bowel and bladder control, temper tantrums, fears of being alone, having nightmares. And so, being patient with them, reassuring them, having calming bedtime activities. Children respond to play and storytelling. A lot of times they'll reenact their issues, and that's kind of therapeutic. With all the age groups, as Dr. Clancy has mentioned, as with any of us, we want to avoid overexposure to the media, especially important for kids because their cognitive ability to sort it out is different. When we look at school-age children, we see kind of similar problems, but now we may see they're forgetting their schoolwork, not doing their chores, maybe withdrawing from their peers, or having stomach aches, headaches, whatever. And so we add on, not only are we being patient, we want to encourage play sessions with their friends, keep up with the educational activities, discuss the pandemic with them, encourage questions. So what's being done in the community? And then, address stigma and clarify information that they get that isn't accurate. And then the next slide, please, deals with the adolescents. So we have all of the same problems, but now maybe a kid that's having problems might avoid school or cut school, may isolate from others. And another one is at this age, children are getting consciousness and social awareness. And so they may be aware of stigma and injustices that they see around them. And so what we want to do is kind of similar to the other ages, be patient, encourage discussion, kind of modulating the discussion, giving them routines with chores, and then also, because of their awareness of stigma, discuss stigma and prejudice and encourage, if we can, altruism. And so the things to include in the family discussion is, more about what the disease is like. We don't know a whole lot about it. We're learning more all the time, how it's contracted, and importantly, hope. What steps are being taken to protect people and them? Next slide, please. So, when we talk about quarantine, we kind of use that word loosely, and I do myself. Quarantine really also means separating out people who have been exposed to the virus while we figure out if they're going to get it or if they have it. And so not only do we have the same problems we have with social distancing or physical distancing, boredom, frustration, but they have fears that they're going to infect others or that they will get the illness. And so, and in fact, many do have stigma aimed at them, and they may have financial loss because they're going to be off work for at least 2 weeks. So in helping them, we want to make sure we communicate in a way that's culturally appropriate in their language if they don't speak our language, don't speak English, and prepare for their needs. And also, since healthcare providers may face stigma and they often are quarantined, we want to make sure they take care of their basic needs because that's something that they're not really necessarily used to doing. And, again, reduce isolation as much as we can. Next slide, please. So as we talk about people who are stigmatized, during this pandemic, in some areas, persons of Asian descent may be stigmatized, as well as those who have traveled and returned from China, Italy, or Spain. So, we can't help but fear getting the virus, but, we want to be reasonable and we want to help these folks not feel rejected. Also, emergency responders and healthcare professionals may be stigmatized, and definitely those who are homeless or disadvantaged, because the perception may be that they're more likely to be ill. So the types of stigma run the continuum. It may be run from avoidance to actually not getting help, healthcare help, or being subject to violence. And so what do we do to help stigmatize people? Always, I know we're always very careful to maintain privacy and also share accurate information with them about the virus. And if we see negative behaviors, speak out against them and help them get social support. Next slide. So as we talk about extra needs, minorities and disadvantaged people are, and so, you know, we talk about our healthcare workers as being on the front line, and definitely they are, but also often women and minorities are as well, and who gives them credit? So they may be in the food supply chain, and they may be dealing with the public who are not necessarily wearing a mask or taking care of their, you know, the deliverers' care. And we have folks that are taking care of the sick and elderly, and the minorities may be keeping the environment clean. So all of these folks are at risk for the virus. Now, often minorities are as well. There may be medical issues, and we'll talk about those. But when we look at different cities and areas, in Washington, D.C., African Americans are 45% of the population, but almost 60% of the deaths. In New Mexico, Native Americans, 10% of the population, almost 40% with the virus. And in New York City, Latinos, about 30% of the population, about 40% of those with the virus. So there may be factors we don't know about. The more obvious one are poverty, certain health issues, which are actually have increased risk for bad outcome, and lack of insurance to take care of the problem in a timely way. This is from the CDC. Next slide, please. So factors that increase the risk of COVID-19 for those who have serious mental illness, very important. So our mentally ill population is at greater risk. We know that amongst people with schizophrenia, up to 70% smoke, and many of them have COPD. There's also a higher rate of things like diabetes, hypertension, and heart disease, partly related to not getting healthcare, but partly related to the treatments. Folks with addictions also at risk, and mentally ill may not trust the medical community, some members of the mentally ill community. And the economic disadvantages are great when you are on disability. So you don't get the best housing. People live in crowded situations. Some may be homeless. Many may not have a smartphone, so they can't get telehealth, which is the way a lot of the community mental health centers are going. And they may not have access to the medications or the counseling. Next slide. So as we look at patients in the United States with mental illness, in better times before the pandemic, almost 50% of Caucasians with mental illnesses ever received mental health services. There's a lot who didn't. But if we look at minorities, far fewer got help in better times. So let's, not a whole lot of research out right now, but if we look at some studies looking at psychiatric facilities, it looks like they have a very high rate of coronavirus. Looking at, over 63 state psychiatric facilities, there were outbreaks of COVID-19. Some of them were fatal. And the problems that were noted in these studies were the need for the protective equipment and how can you get space if you're crowded? Lots of support is needed. Now, federal help, I think, should be coming. One of the things that's good is there's a COVID telehealth program, and that's providing funding to basically nonprofit facilities, including mental health centers and teaching hospitals, in order to support telehealth and telemedicine. Next, please. So looking at the international studies, there's a few things out. One I thought was interesting, looking at Wuhan, which is kind of the ground zero for this virus. And in one mental health hospital, 50 of the inpatients and 30 of the mental health professionals got COVID-19. And they noted similar problems. They didn't have protective equipment. They couldn't quarantine. And international journals looked at different risk factors and found that older adults and migrants had more mental health needs during the pandemic. So, you know, they often are isolated. And when they looked at the COVID isolation wards, most of the health professionals didn't have mental health training. So we need more mental health interventions available on those isolation wards. Next, please. So social media may be one way we can gather information. And so this is, you know, it's hard to do a study when you've got to get informed consent and explain a research study to people. So Facebook is a good way to go. People can be at home. And so this is a website or a group on Facebook called For Like Minds. And they did this survey about mental health. And about 200 people responded as, and they self-identified as having a mental illness. It's a variety of things that they had. Almost 3/4 had 3 major issues, problems. They thought their mental illness would get worse. They thought their medications would run out, and they thought they couldn't receive mental health care. That was their fear. And social isolation was one of the issues that they talked about. So what was their preferred communication? As you might imagine, this was a Facebook survey, so they liked social media and texting. The ones that were coping poorly really didn't like to use their phones. So let's go to the next slide, please. And so what do we do for Alzheimer's patients and those with cognitive impairment, and especially for their families who are caring for them? So first of all, we really want a set routine that's predictable. We want to get fresh air and exercise. Music is a wonderful way to go with elders, especially old music. Games. Really want to avoid the excessive watching of news. You might think that the elder is not understanding it, but they are, and they're very sensitive to the emotional content. And so we really want to modulate that. And of course, make every effort to have safe social contact. When there are behavioral acting out problems among the patients, we want to figure out first what's causing it. Are they bored? Are they all upset by the news? Lacking stimulation? Are they in pain? And then, you know, contact the primary care physician if it's a medical issue, the psychiatrist if they're on a psychiatric medication. And, you know, they can respond to distractions, deep breathing, and trying to calm them. Now, the caretaker also has to take care of themselves. So these caretakers often are worried about their loss of income, about being isolated. They're worried about their loved one becoming ill. So again, the same relaxation things we've talked about and that Dr. Clancy has talked about. And for more serious symptoms, we encourage getting treatment. Next slide. So how do we notify a family member after a COVID-19 death? So, you know, I remember after the Oklahoma City bombing, I was a lot younger, and many of us volunteered in the Family Notification Center. So, and had no experience giving this bad news, but we learned a lot from the clergy. So, because they were used to doing that. So who in this case is going to be notifying of a death? It's not going to be the mental health professional. It's going to be usually the healthcare worker that took care of the patient. And so here are the recommendations. First thing, be prepared. Know something about the patient. In delivering the bad news, empathy goes a long way. Just that statement, I have very sad news to share. I'm so sorry about your loss. And we always are prepared. Losing a loved one is going to bring a lot of strong emotions. And so we hear them non-judgmentally. and we can provide some support access. There are grief support groups and pastoral care that are going online at this point. And, you know, a note, sympathy note later on goes a long way. Next. Let's see, can we go back one? Okay. So if people are just stressed and not having diagnosable mental illness, these are the recommendations. Again, connecting, educating, talking to the doctor, relaxing. And pets are important. I don't know how many times I've done telehealth and seen a cat or a dog on somebody's lap. So it's very therapeutic. So we can tell our patients about, to talk to their employers about FMLA, and because they can get 12 weeks of leave. Hopefully they have some paid leave, but this is to take care of themselves or a family member. And again, when the quarantine or the distancing is up, there can be mixed emotions. And I think we'll all be relieved. There may be, waves, but I think we'll feel better when it gets better. Next slide, please. So here are some resources if a family member or friend needs immediate assistance for a mental health problem. So we've got disaster distress helpline, the National Suicide Prevention Lifeline, and there's one for Veterans Crisis. And next one. Local resources, we've got the Homeless Alliance, we've got Meals on Wheels for Ending Hunger. There are several mental health connections, and I think the Department of Mental Health has one as well. And for our physicians, we've got the Oklahoma County Medical Society Physicians Wellness Program. Basically, free confidential visits, up to 8 visits for members. And the hours are extended and there's no health record or insurance. Next slide. And so I wanted to share, I'm very proud of this medical student, Landon Hester, and his mentor, Dr. Kevin Watson, sorry. And they developed a website called Fight for Mental Health. It's actually appropriate for people needing help now. So it's broken down into several problems that people can have. So we've got the Fight Depression group. We've got support, links to support through NAMI groups. We've got referral to a book, Feeling Good, the New Mood Therapy, and then apps for, cell phone apps for helping with depression. For calming anxiety, we've got a mindfulness meditation online course, and we've got a Breathe to Relax app on a smartphone. There's recommendations for sleep problems. And next slide. This is actually a traumatic experience. Many folks may develop PTSD, depending on the amount of exposure and trauma that they have. But even without PTSD, there's a wonderful app developed by the VA called PTSD Coach. And it's online or an app. We've got a lot of addictions referrals to AA, NA. There's a therapy-based support group, rehab, help with, there's an online drinking tracking program, tobacco help, and gambling assistance, including chat rooms and information for self-exclusion from casinos. And then also help for reaching Overeaters Anonymous, etc. So next slide. So we've talked about the different areas that have stressed people, fear of the virus, isolation, economic problems. We talked about special needs people and how to help them. And we've talked about resources for helping patients with normal stress and if they need mental health interventions. So thank you very much.
Great job, Dr. Clancy and Dr. Tucker. Wow, that was a really nice presentation and very timely. We needed that. It looks like we may have time for 1 or 2 questions. We've got a couple of minutes left. This one's for Dr. Clancy. I do telemedicine and many patients are having problems with panic attacks. Any short-term medication you might recommend?
You know, it matters the level of severity. I always recommend first and foremost, if possible, cognitive behavioral techniques first. The antidepressants like the SSRIs, fluoxetine and paroxetine are good long-term medicines for panic attacks and can lessen the severity of each attack and lessen the frequency. But that takes oftentimes 3 to 4 weeks to work for panic disorder. In the meantime, if they're very, very severe, oftentimes I move to a benzodiazepine, and really just 3 or 4 days worth is where I go with that, just to kind of get them over the hump as well.
Okay, and we might have time for one more question, and we'll share it with Dr. Tucker. Home health patients are very fearful right now. Many refuse attempts by staff to come over to do assessments and treatments. How do we overcome these fears?
That's a good question. And I think very important to educate the patients. Of course, I guess we're going to talk to the patients through telehealth about these issues. And I think we tell them that usually the healthcare workers are monitored and that they're safe. Hopefully, the healthcare worker is wearing a mask and appropriate protective equipment. And so, the patient's life depends on their getting proper treatment. So I think educating and ensuring the patient that the healthcare worker is protected. And I know the agencies go a long way in making sure that happens. They educate their healthcare workers.
And just to wrap things up, we're pretty much out of time. We had some other great questions, and we'll see if we can get those answered and posted on the webpage. Anything else you want to add, Dr. Clancy or Dr. Tucker, for today? And again, great job.
I would just add, and this is actually came from you. We are using the term social distancing, and it's pretty much taken over across the country. But George, you pointed out, really, we don't want to socially distance. We want to physically distance and stay socially connected. And I couldn't agree more with your comments on that. I think hopefully we can change the terminology and the language across our country on that, because what we're seeing is some people believing they can't leave their house whatsoever. And the quarantine has been taken so seriously that it's really, really restrictive to them because they're so fearful that outdoors is dangerous.
I totally agree. That was a good point. And I think now with people starting to kind of come out, I think there's a lot of concern about what are we going to expect. And so I think we'll just see what happens, and hopefully our leaders will be careful in protecting folks.
Great. And again, we want to thank all the OSMA staff for putting this together. We also want to once again thank our sponsors. And thanks again to Dr. Clancy and Dr. Tucker for this really informative talk. And with that, we'll end it. Have a great rest of your weekend.
Thank you.
Thanks.